Good afternoon and welcome to session one of this learning community. This learning community is building resilience, navigating crisis amidst evolving environments. This is specific, well, not specific, but this is for behavioral health providers and organizations serving refugees and migrants. And we're glad to have you all here today. We're going to allow a little time for people who will be jumping in. And wherever you are in your day, we're grateful that you're taking the time to spend this time with us. And we're also grateful that you're allowing RMTAC to support the amazing work that you do. Thank you so much for joining us. Okay, let me introduce myself fully. I'm Dr. Trenton Fedrick. I'll be your host today, and I'm a clinical consultant for RMTAC, which is the Resource Empowerment Technical Assistance Center for Behavioral Health. Today, we're diving into navigating change, building resilience for organizations, for ourselves, and those who serve to best prevent crises. In the second session, which will be next week, we'll focus on the de-escalation of crisis. We hope through this learning community, we can foster a collaborative environment where we can share knowledge, resources, and best practices. That's the power of this type of learning community. What differentiates this community from a webinar is that in these learning communities, you're an active collaborator. You collaborate and engage, and you're encouraged to engage. SAMHSA, our funder, really emphasized creating the learning opportunities to help providers in this space apply what you learn and personal life as well as on the lives of those we serve. The great thing is you also have RMTAC to provide more personal and intimate consultation from one of our experienced clinical consultants if your organization needs it. And as far as the session goes, I encourage everyone to share their insights, ask questions, and support one another throughout the session. All right, as you can see from our agenda, we have a robust session plan. We'll begin with introductions, of course. We'll do an icebreaker with some mindfulness. And then we'll, of course, hear from we'll do a sessions overview, topic introduction of crisis prevention. We'll hear from our subject matter experts during the panel discussion. And you'll have an opportunity to ask questions and share your insights with our panelists. We'll also, of course, do session summary and takeaways and give you closing reminders. I'd like to take the time to introduce our subject matter experts, whom you'll be hearing from during our panel discussion. We have Dr. Rosalind Ghaffar Rogers, clinical behavioral health subject matter expert, Dr. Gaurav Mishra, a medical doctor and MBA and a health systems consultant, child, adult, and public health psychiatrist, and Dr. Sebastian Simpija. And I know I just destroyed his name. A clinical director with Sebastian Family Psychology Practice. But he'll say his name. Yes, sir. All right, he'll give us his name later. You'll get to hear it. We also have backing us up our producers. They're taking their time and their opportunity to kind of cover and pay attention to things and keep us going. We've got a solid group, as you see, Diana and Sonia. Now, as a part of our learning community, is we're going to do an icebreaker. We always do one, and this is an opportunity for you to connect and disconnect from work and take a moment to connect with yourself. As humans, we need that connection and we need that energy. Our line of work can specifically get heavy because we carry the woes of so many others. So, and especially during these changing times, we are definitely affected. So what I'm going to do is I'm going to turn things over to Diana for the next few minutes, and she'll lead this activity.
Hi, good morning, everyone. Nice to see you all. We'll go ahead and move into the next slide. So if you can, please enter 1 or 2 words to describe how you're navigating change at this time. I know we're all dealing with a lot of change at this particular time. So, how are you navigating that? You can go ahead and scan that QR code or join through slido.com with that number there in the lower left hand corner. Looks like a couple people are typing. So, our whole focus today is navigating crisis through evolving environments. And I'm sure many of us feel that we are often evolving and changing and dealing with change, especially in the nonprofit space. So, how are you navigating that at this moment? I love that. Okay, so we've got hope, compassion, routine, therapy, stressed, exploring, partnering, optimistic. Okay. Compassion, emotional intelligence, breath work. I love that. Faith, cautiously and prayerfully, humility, education. Therapy. That's a big one. I'm exploring that on my end as well. That seems to be a popular one because it's since it's showing up larger, that shows that a lot of people put that one. We'll take a couple more. Connecting. Ooh, overwhelmed and fatigue. Okay, so there's a lot of different perspectives coming in when we're navigating change, and that's all valid, right? We are all experiencing it in different ways. We're taking in a lot of new information. We're trying to explore how that shows up in our lives, how it affects us. Perfect. Okay, so today, in the spirit of navigating change and helping us ground a little bit while those things are occurring and while change is really at the forefront of the work that we do, one thing that's really important is that we take care of ourselves, right? And the way that we can do that is maybe through therapy, through grounding, through prayer, through breath.
All right. Why this topic? Well, the landscape of behavioral health provision for refugees and migrants is fraught with unique and evolving challenges. We grapple with cultural and linguistic barriers, profound trauma of displacement, and the constant flux of policy and resource availability. This creates a volatile environment where our clients' needs are often compounded by our own organizational strain, excuse me. However, resilience isn't simply about weathering the storm. It's about building a robust vessel capable of navigating future crises. By embracing adaptability, investing in our people, and forging strong community partnerships, we can build resilient system that effectively serves the vulnerable populations that rely so heavily on us. Another reason we chose this topic is because we had received numerous CTA requests from the providers that have shown a significant interest in crisis prevention and de-escalation for migrant and refugee populations during the current environmental changes being experienced by the population we serve. Our goal is to learn from the experts and engage in a discussion with fellow health professionals. We'll share experiences and strategies to address crisis prevention with an evolving environment that we're currently in. We aim to analyze crisis situations and find effective ways to guide our teams through change and loss, and develop strategies for crisis prevention and resilience, including spotting early warning signs. The APA defines crisis as a situation that produces significant cognitive emotional stress in those involved in it. Perhaps, for example, just the crisis of attempting to come into the country, even with in a way that you assume would be considered legal, that you find out later is possibly not considered that. Crisis can also be defined as a state of overwhelm, inhibiting the ability to cope. For this learning community, we refer to these definitions of crises and apply them to what can be experienced at an organizational, provider, and refugee level during times of change. The domino effect of navigating crisis. During times of change, there may be factors beyond our control when attempting to prevent crises. However, What remains within our control is our response, which can significantly mitigate potential crises. The way an organization responds will impact its providers, and how these providers individually respond can positively or negatively influence their clients. The process may look a little something like this. Crisis originates. A sudden policy as a shift, natural disaster, or economic downturn creates immediate stress and uncertainty within the community. Organizational response. Organizational leadership plays a crucial role in preventing the escalation of crises. During times of significant change, organizations can become overwhelmed with increased demand for services, sudden lack of resources, operational disruptions, or staffing challenges. The way leaders respond can either create uncertainty or foster transparency, hope, and alignment with the organization's mission while navigating these changes. Provider response. The strain in organization can affect providers, the staff themselves that provide direct service, who may experience compassion fatigue, vicarious trauma, or burnout. While providers may not be able to influence how an organization responds to change, they do have autonomy over their own self regulation, self care, and capacity to manage stress and crises as best they can. And finally, client response. Clients possess their own ability to respond as best they can. However, their capacity to manage crises is greatly influenced by the support they receive from organizations and providers. When organizations are overwhelmed and providers are strained, it becomes even more crucial for professionals to support one another and respond thoughtfully. By fostering a collaborative and compassionate environment, we can help clients navigate challenges more effectively and prevent crises from escalating. It's time that we prioritize our missions and values. Within organizations, change is consistent, but remembering why we do what we do can help overcome instability. This focus on mission can be the catalyst for overcoming uncertainty because the mission of those we serve does not change. Reflecting on the why can maintain passion in turbulent times. By staying mission aligned, organizations can mitigate some of the repercussions of organizational crises, helping ground the organization in changing times. Prioritize core missions and values. Revisit and reaffirm the organization's core mission and values. This provides a stable foundation during turbulent times. When we talk about best practices under CARF and COA, some of the things we talk about is always looking back at your mission and recognizing and being within your focus. Ensure all actions and decisions align with these principles, reinforcing a sense of purpose. When we look at building strong internal support systems, you can help your organization stay mission aligned by providing opportunities for staff to debrief and share experiences and offering mental health and wellness resources. Build strong internal support systems. Provide regular opportunities for staff and volunteers to debrief, share experiences, and support each other. Offer mental health resources and training to staff to mitigate compassion, fatigue, and burnout. Organizations working with, when we start talking about resources, organizations working with migrants and refugees must remain agile and informed, especially given the rapidly evolving nature of policies, global events, and community needs. Here's a breakdown of some key sources that may help us stay up to date. The Office of Refugee Resettlement, Department of Homeland Security. Internal organizations include some of the United Nations organizations, the Refugee Council in USA. These are private non-for-profit organizations, the U.S. Committee of Refugees and Immigrants, National Immigrant Justice Center, professional networks and associations, and other reliable news sources and academic and research institutions. Self-care for organizations and providers can include the establishment of clear boundaries, encouraging staff to set boundaries between work and personal life, Provide regular debriefing sessions. Sometimes group supervision can help, giving partners time to talk to each other and hear from each other. Promote self care practices. Encourage staff to take breaks and engage in physical activity. Limit exposure to stressful media. Constantly consuming news and social media related to crises can exacerbate anxiety. We have to set these boundaries and limit exposure to overwhelming information. So, at this point, do you have any thoughts and feedback? Before we begin with our panel, we'd love to hear from you. If you've popped some things, I'm going to make sure my chat keeps closing on me. I'm going to see if there were any questions. I didn't see any particular questions in the chat, but if you all have any questions, if there are things that you're curious about at this point or things that you'd like to add, this is a good time to give that feedback. We'd like to be able to get a good sense of everyone's background, and this will help tailor our discussions as we progress. This will also help tailor as trainings come, as we put trainings out in the future. So it looks like 7% said there was an increase in morale, 60% a sustained morale, and 33% a decrease in morale. That's actually extremely interesting, because when we start talking about a decrease in morale, often what we do forget is that our leaders sometimes can become overwhelmed and find it difficult to navigate the change, especially when they're hit with unexpected situations. The current environment has been a bit unexpected. All right, we are now excited to hear from our panelists. As your host, I'll mediate the conversation and ask the questions. We'll explore various perspectives on crisis prevention at the organizational, provider, client levels, including refugees and migrants. As you pop questions into the chat, I'll occasionally pop in when I can as the panelists are presenting to ask those questions for you. And I guess we can begin with Dr. Rogers, because that's the top face on my little screen.
Okay, well, I'm glad to be here with all of you. Seems that discussing this topic is obviously very important, but also quite timely. So I am an international psychologist and a mental health and psychosocial support consultant and a licensed mental health counselor. I was working as a consultant with USCRI, so the U.S. Committee for Refugees and Immigrants. And then I also became employed by them and became in the role of a clinical behavioral health subject matter expert. And this was in terms of crisis situations. I started working as a consultant with USCRI back in 2021 during the US-led evacuation in Kabul, Afghanistan. And because I am half Afghan myself and half American, I anticipated the mental health needs, knowing that there were so many Afghans and the thousands, arriving into the United States. So that in and of itself, the kind of chaotic evacuation, and then their arrival here in the United States, and all the organizations and government agencies kind of just scrambling to get everything situated to meet the needs of all these Afghans. I think it was around between 80 to 90,000 Afghans who arrived in the United States. So with USCRI, we were tasked to develop and implement mental health and psychosocial programs at all 8 of the military bases across the United States, taking care of Afghan refugees or processing them. Again, I had heard from them. I was on the ground at Quantico, and I heard from the Marines that they were all coming on route somewhere. I don't know where they're going. And literally in mid-route, they were turned around and taken the other direction to go to Quantico and assigned with a whole new task and agenda for the next couple of months. So that kind of set the pace for what was to come. So we went there. Obviously, there were a lot, from an organizational standpoint, as well as kind of interagency partnership collaboration. There was definitely a crisis as well as all the way down to the individual level, dealing with individual clients who were in the midst of crisis, whether it be suicidal ideation or domestic violence, and all the other host of issues that would be considered a crisis. I
It sounds,
also,
yeah.
yes.
No, I was going to say, it sounds like you've run into a number of crises in your time, Dr. Rogers, and I was just curious about, because we're having you all here, perhaps what Dr. Mishra and Dr. Sebastian may have run into, and so you all, so we can all get an idea of what's really going on out there.
Yeah.
Yeah.
Yeah, and I understand, and I want to preface everything that I said with, that this was a very unprecedented, unexpected event that happened here on, U.S. soil. I think the last time anything like that happened was, during the Vietnam War. That was a very unusual situation. I think that many of us from the Afghans who arrived here all the way up to federal coordinators were very unprepared for what was to come, as well as all the coordination that was required among all the different organizations and government
Mhm.
agencies and community partners. It was just so much collaboration and getting everyone on board. I also worked, we had an emergency, talk about emergency. USCRI was called to provide mental health and psychosocial support that was culturally responsive to unaccompanied Afghan minors that were at 2 shelters in Chicago. They were expected to be transferred again from the shelter that they were at to another shelter, and they were refusing to leave.
Oh,
And
wow.
they, bless their hearts, they had, been very proactive in appropriately expressing their concerns and their feelings. They'd written letters to ORR, explaining the situation, the reasons for not wanting to be transferred again. So I was literally within 24 hours, flew out to Chicago to handle that. And then also after that, I worked in Michigan at 3 different shelters for unaccompanied, with unaccompanied Afghan minors. And we had 3 different teams on the ground looking at those shelters. And there were definitely many crisis situations during that time there. So.
Wow, that's a lot. And Dr. Mishra, have you had some incidences, and tell us something about yourself as well?
Yeah, thank you. Yeah, great to hear some of the experiences from Dr. Rogers. So I'm Gaurav Mishra. I'm an adult and child psychiatrist. I'm just actually in the process of stepping away from the role of Chief Behavioral Health Officer at San Isidro Health. We have a large FQHC on the US-Mexico border. We serve about 160,000 patients. So my experience as far as dealing with crisis, obviously one from the perspective of, direct patient care as a clinician working with patients in crisis. I would say as an administrative leader in the organization, we had about a 1.5 year period where my kind of operational counterpart kind of had to leave, and we were without an operations counterpart for about a 1.5 years. So it's managing essentially all of the different aspects of how patient care is delivered, along with operational and clinical oversight, was something hugely challenging. But I think one experience I think I definitely want to mention is about working with unaccompanied minors along the border. So, in 2021, unfortunately, as people remember, we had thousands of kids separated from their families and housed in different locations across the country. And we just happened that in San Diego, we have a large convention center where about 3,500 kids were housed there. And so my organization, and then through them, me as the departmental leader, was kind of tasked to oversee all of their mental health services. And it was very challenging, but I was very lucky to have had that opportunity because, again, as Dr. Rogers mentioned, it is really amazing to be able to work with many different organizations, both federal, state level, and also county level. But also it provided a huge amount of flexibility in how care is delivered. So we were able to, a lot of times you have many restrictions working within a health center, whereas, some are very good and some restrict you from actually doing great work sometimes. Whereas here, we were able to kind of design our own system and what works. And we went from, so 3,500 kids, you can imagine, if you have everybody do therapy one-on-one or psychiatry, that's impossible target to get to. But within 2 or 3 days, we trained our care coordinators and case managers to start running groups. We were doing 4 groups a day of 30 kids each. And so 7 days a week, we're reaching over 800 kids every week. So now once we got to that numbers by changing how we delivered care, the crisis was real, but we were able to deliver really comprehensive and good quality care to people who needed it at the basic level. And then anybody who had more severe illness or psychosis or suicidal ideations or autism undiagnosed, those were then seen by clinicians one-on-one and really be able to triage it really well. So that was an exciting experience. So my brain always goes to solutions, and somehow that's that's how it works. Even in the worst situation, there is a way to do things which are not traditional, but are still very impactful. Yeah.
Yeah. And so, Dr. Mishra, all that occurred during that border crisis?
Mm-hmm.
Wow. 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 Dr. Sebastian, tell us about yourself, your background, and the crises that you've encountered in your role.
Yeah, thank you so much. Thank you so much for Dr. Trenton for leading us, and I appreciate my co-panelists here and those of you who are attending. So I happen to wear several hats. I'm a licensed psychologist working with children, families, adults, pretty much the entire lifespan. I also lead a team of clinicians, about 40, who include psychiatrists, psychologists, master's level trained individuals, as well as master's and PhD trained individuals looking for licensure. We also have non-degreed individuals who work with us in different roles, from providing mentoring, clinical support and assistance, to also doing a range of services. We are both are based in the office, but also a lot in the community, in the schools, partnering with our local urban school district, but also in people's homes, places of worship, meeting folks at work if that requires that. So a model that allows us to be where the client is, to eliminate barriers such as transportation, even including challenges with technology. So the crisis we deal with, of course, I would rather have a more stable, predictable life and the way of running my clinic than having to deal with the crisis. But crises are here, and indeed, as you have indicated in the beginning, we have to expect them, especially now when there's so much uncertainty. So I'll give an example, a couple of examples. I'll give an example of a clinical crisis. I'll give an example of an operational crisis. I also give an example of teamwork collaboration. Clinical, I'll have two examples. The first one is patients who are getting psychotropic medications from us. So that could include medication for anxiety, for depression, for sleep hygiene, particularly PTSD medication to manage nightmares. So we've had moments when our clients, most of them are Medicaid, have been steady, very good attendance of their appointments, upwards of 90% attendance, which we are very proud of, because we build very good relationships with them. But the crisis comes up when a client calls you that the pharmacy cannot fill their medication because there is uncertainty of their insurance. So now somebody who is on medications that really help them self-regulate so they can live their lives, take care of their families, go to work, and now they're in threat of not having their medications. That has been one of many crises that we've had to deal with. In fact, a couple months ago, but also mostly in the middle of COVID, we ran out of anti-anxiety medications in our region here, where major pharmacies such as Walgreens, CVS, even Walmart were running out. And those moments were difficult to deal with when you have folks who are relatively stable, but now threatened by not having their medications. That's very difficult to deal with. That's one example that is clinical. Another example of recent arrivals, because of the overload of stress, we've had cases where folks will present with seizure-like conditions, with all the indications of a petit mal or grand mal seizures. which requires us to collaborate with our physical health providers who run all the tests, and all the tests are coming back not showing a physiological cause for the seizure-like conditions. Those moments, which now families are dealing with them and they need help, have been very, very challenging and requiring significant collaboration. That's the clinical portion of our care and the crisis example. Another example is which many of our resettlement agencies and our case management agencies, although they are working very hard to sustain their staff, are now having to manage recently arrived individuals who cannot get case management. For example, finding housing, registration, enrollment in school, assignment of primary care providers, and all those anchors that a new or arrived person needs are not there. And so our partner agencies trying to stretch their resources and covering services for which they're not being reimbursed, and then making sure that their staff are stable, staying on mission, feeling supported. That has been an incredible source of
and that's extremely important, Dr. Sebastian. And it makes me ask the question, what approaches can these leaders do to guide their teams through these changes and losses? And I'm asking all of you, like, and how can these organizations uphold the mission that they're determined to keep pushing forward?
I will, if that's addressed to me, let me go back to the two clinical scenarios I have given, especially with the seizure-like condition. So the action plan has been that we have a team, multidisciplinary team, that also involves dealing with primary care providers, even large hospitals. So we have a pre-established relationship with many of these entities. So we are able to talk together. So that has made us review our mission, our vision, and our capacity to collaborate, particularly when there's a crisis. So whereby it is easy for me, the director, to pick up a call and call a medical director at a clinic and talk to a doctor there, a nurse there, to give us guidance. Where we've been able to navigate for our patients who don't have insurance, but we can guide them to clinics that so far, thankfully, are able to provide medications without having to bill the medication recipient. So that, to me, has been an incredible resource. So utilizing and nurturing and strengthening existing collaborations and having them ready to act when there's a crisis. I'll stop there to allow my other partners on the panel to answer.
Yeah, thank you. I mean, I think, I definitely have a comment on this. I think one of the most important pieces I would say, if any of the audience are leaders themselves, or it would also apply to if you have a leader, right? You want to work with. The first important thing often many organizations don't do is even acknowledge formally that there's a crisis. Unfortunately, sometimes in healthcare, we are thinking, we don't want to share this information, it's going to scare everybody. No, all of these people are adults who are in the workforce, who are willingly coming to work, hopefully, and are able to handle that information. So that even acknowledging that the crisis goes a long way in building trust with the organization to see, okay, somebody sees this is a problem and they're working on it. The other big thing is, if you are not in a leadership role, I would say you should demand this of your leadership, to be more open and communicative. So I think the frequent communication is a huge piece of it. Even saying we don't have it all figured out, but we are working on it, goes such a long way in giving confidence to team, versus you can definitely trust that everybody knows something is wrong. Oftentimes, because they don't have the information, they are assuming the worst for sure. They're not assuming the best case. So I would say the more you communicate to your team and frequently and trust your team, the better the outcome will be and preparedness will be.
Yeah. And Dr. Rogers, right before we hear from you, because I want to hear from you as well, Susie Beck put in our chat, our staff that were furloughed were offered a place to meet weekly during the time period they were laid off. We also held an all-staff dinner to enjoy one last meal as our full staff together. It's been helpful for all the staff. Unfortunately, I need to leave. Well, that part you don't need, but it's been helpful for all the staff, is what she's saying. Dr. Rogers.
Uh, yes, yeah. I think supporting, obviously, what leaders, that's supporting their staff and their workers and their team members in any way possible. And I think that also, touches upon other points that were made by the other two panelists in terms of communication, also in terms of capacity building, capacity building that's aimed not only on stocking procedures or structures or resource reservoirs, but also building robust professional communities of practice that are able to effectively intervene and cooperate when they're needed. And I think that regular training, I know that employers give kind of those mandatory trainings that are required for whatever it may be in their field, but I think that there needs to be more of a culture of continuous learning and training because this field, forced displacement and mass migration is a constant, but it's also constantly changing, right? So having, new interventions or new approaches or frameworks that have been developed, and providing those trainings to staff is extremely important in terms of preparing for crises. Also, I wanted to just comment on, one of the things that I really appreciated when I worked at Quantico, and this was in an entire interagency coordinated effort that we did, was that we did a kind of a collective post-crisis analysis, because crisis situations are opportunities for growth and learning, right? So to identify the weaknesses, to identify the strengths, what worked, what didn't work, what can be improved upon, what things do we completely miss altogether. So incorporating kind of lessons learned into planning and training and preparation for the next crisis is going to be extremely important. And when engaging in this process, it's also extremely important to include the experiences and voices of all stakeholders involved, including refugees, right? In order to ensure that all perspectives and the dimensions of a crisis are addressed. And we've already heard of this in terms of, lack of coordination, between different service systems and organizations, insufficient funds. I mean, there's a whole, I think we could have an entire learning community just on what doesn't work. So I think that learning those lessons, or even reaching out, if your organization hasn't been through it themselves, reaching out to organizations who have, and taking their experience and their lessons learned and incorporating that into your programming is going to be very helpful.
Yeah, yeah. So I also noted. I also had a quick. There's a quick statement in the chat from Karan Bellinger, and it's actually an extremely important statement. The person asked, do you feel there's a lack of celebration experiences to help offset the level of intensity and work, both for clients and staff? And he clarifies it by talking about the fact that we do a lot of low energy stuff. We do a lot of meditative stuff. We do a lot of mindfulness. We do less celebratory stuff, less things to bring laughter and music. And the crazy thing about it is it kind of helps you understand, for example, and I'm going to talk about death for one quick second. When in New Orleans at a funeral, there's a large celebration. Now, the reason I brought up death is because, unfortunately, often when we're doing this work, we in this process, we end up seeing the death of programs, the death of situations, and the death of opportunities when we're trying to help populations in need. And sometimes we need to do something other than pray and wallow. And sometimes we need to kind of celebrate the fact that we've had an opportunity to at least go as far as we've gone and been able to help those we have helped. And remember, we have helped those in the past. There's a lot of changes going on. Is it possible, could you all share some examples of successful crisis prevention initiatives, some of the key factors that contribute to building good resilience?
So although what I'm about to describe wasn't initially created or implemented as a prevention initiative or strategy, I think that there were many components within the program that we delivered at Quantico that were actually ended up kind of being preventative. And so we had a whole cadre. We used kind of a humanitarian framework when we developed our program, our mental health and psychosocial support program for Afghan refugees at the 8 military bases. And when I say using a humanitarian framework, is that we took individuals who spoke either Dari or Pashto understood Afghan culture, because that's obviously the population they'd be working with. And they were just lay people, but we trained them in mental health first aid as well as psychological first aid. And we used them at the military bases as community health workers as well as behavioral health case managers. We also had, for example, I was at, Quantico. There were other mental health professionals, licensed, and trained mental health professionals as well. But the role of the community health workers and behavioral health case managers were going into the community and meeting refugee clients where they were at, and building trust with them, introducing themselves to us and what we do, and providing them with any kind of information or support that we could in the moment. And they were also tasked with identifying possible high-risk refugee clients who would then be referred to a mental health professional or a medical provider on the team or on the base for screening and assessment. And so this early screening, referral, and intervention all fall under prevention. And also, I think it's really important. We had a little bit of difficulty with the public health and military mental health providers that were there, because they were confused by the program that we were providing, because we were using lay people to do some of the work, even though they were trained. And I think that builds capacity. And also, obviously, there's a huge shortage of culturally competent, particularly mental health professionals in the United States, to meet all the demands across the population, including among those who are forcibly displaced. So in this way, I think that it really did become a preventative intervention or initiative, particularly with the early screening. We also provided psychosocial groups that were gender segregated, that in each group session, we had cultural orientation, psychoeducation, community building activities, coping skills development, information about relevant resources and how to go about obtaining those resources, as well as cultural strengthening. So these groups were very preventative in nature because they built upon refugees' existing strengths and enhanced all the protective factors in their lives, help them develop additional coping skills to deal with the possible stressors and challenges that were waiting ahead of them in terms of resettlement, as well as providing them knowledge to navigate their new environment. So, and also a space where it could be peer-to-peer support, which I think is also very important as well.
Those are some great internal supports. What role do support networks, family, community groups, interpreters, and so forth play in the crisis prevention and resilience building for organizations?
I can take that. I think it's a huge piece of the puzzle that unfortunately healthcare in general has kind of forgotten about or not thought about seriously for a long time. I have patients with dementia. I'm a child psychiatrist. I'm seeing like 4 to 85 or 90-year-old patients, but I have patients with dementia. The person I'm really talking to along with the patient is their daughter, who's taking care of them. And it's really in many ways, I feel like they are my patient too, because they're really doing the difficult work. I can provide my recommendations, everything. They are really carrying the burden of the care that the patient needs, and that's true in many ages and in many ways. So I think one of the things healthcare organizations kind of overlook as a partner is for somebody who needs support, that's a family, but also as a partner who can really help in recovery and wellness is the community links, the religious links, the family links, and all of these things can be huge sources of support for our patients, oftentimes more than we can. And the fact that we can acknowledge that and help them integrate with all of those supports can be hugely impactful. And I think that is unfortunately we have difficulty allocating resources to make sure the support givers have the support, have the help to actually do the work. So that's something I really think we need to continue focusing on.
If I may add on Dr. Mishra's observation there.
Yes, Dr. Sebastian, please.
Thank you so much. So if I may add on that piece to really refocus on the role of the family. Family could be a nuclear family. It could be families that especially live with various generations in the same household or next door to each other. But families could also include informal supports from the neighbors next door to a school teacher, a school social worker, a school psychologist who comes to a home to visit students to make sure that their attendance at school is regular. All of those folks become part of the team, and caring for them to see that the situation does not deteriorate their own resilience is key. And so then hence the necessity to have regular meetings with that team to so that we are all on the same page. I will end with one example that has been very interesting for us. We had a patient living with bipolar for 2 years, a young mother with an infant then, now that boy is about 3 years old, who had refused medications all along, even before she became very sick. We tried to get her admitted several times. She would not accept. But eventually she did accept. And the motivation for her was from her own children, telling her, "Mom, when you're on your medications and you're doing well, we love playing with you, making sure that you continue cooking our food that we miss so much, that you spend time with us." These children's feedback to this mother have made all the difference in encouraging our patient to be more consistent with her medications. We have now moved her from injectable medicine back to the pills, which are every day. But we had to use the injectable mode because it was only once a month. We got her to that space. And now she's moving to daily pills that she wants to use and avoid the injections, assisted by her children, encouraging her to do that. And a good example for how the families can be very supportive in moments of crisis.
Great. That's excellent. When we talk about our clients, for example, what should we be looking for? What should participants be looking for when it comes to identifying crises in clients in the populations we serve?
I want to start with just saying that in terms of mental health signs, symptoms, it's all of that is within the cultural context. So that's just want to keep that in mind. That's very, very important. And I know that one of the panelists had mentioned clients demonstrating showing up with seizures, but it was really a somatic manifestation of psychological distress, right? So that was, and when I was working at Quantico, we had a whole, I would say, about a dozen women who were fainting all over the place. And the doctors were checking them out. They couldn't understand what was going on. But it was they were having panic attacks, and they were fainting, and that's how it was that's how it's expressed in Afghan culture, for example. So I think it's really, really important. I just wanted to preface this discussion for this question that cultural context plays a huge role in how individual refugees experience their symptoms as well as express their symptoms. So it's important that as providers and organizations, we understand and really look for those within a cultural context.
Okay, wow. So, Dr. Mishra, Dr. Sebastian, do you see? Can you help them identify other warning signs when there's heightened crisis in migrants?
Yeah, I mean, I think one thing that's like completely, I think, following what Dr. Rogers is saying is it is important to like acknowledge what your expectations are going in first, because this is something I experienced myself at working with unaccompanied minors. The stories that we would hear are very traumatic, right? However, I don't want to disrespect the kids by saying they were resilient, but the reality was many of them, I would say 90+% of them, told me that they had an expectation of a traumatic journey, but the expectation of being separated from their adult person within the United States was not an expectation they had. So for them, that separation was more traumatic than I heard stories about being shot at, sexually abused, raped across the journey, and that was very difficult to hear. Like difficult to hear that this kid has gone through this. And again, obviously, as clinicians, because we are trained, we look at and okay, this person obviously has so much PTSD and trauma, but the reality was they, in many ways, some of the things they left behind were very traumatic, begin with every day. But what they didn't expect is that this land of hope, or once they arrive, it's going to be amazing kind of picture that had been presented to them was very different. And and so even that separation at the border and kind of treatment with Border Patrol was more traumatic in the moment. And for them, they needed, the uncertainty was huge, another factor that they were dealing with in the moment. So they did not need me or anybody diving deep into their trauma or even kind of talking about it, unless it was on the surface for them or impacting their function, but really function. And how do you manage uncertainty? How do you manage when you're going to get out of here? How do you manage that you can't talk to your grandma who's sick in your home country and you can't? I mean, those are the things that was on the surface. So really taking a step back, because it is difficult work to do. So recognizing how do you feel about it? How are you addressing your own kind of response to it? And then getting to the level of what is needed by the person themselves and not what you think they should be feeling.
So when we talk about, and I'm just going to hit this quick because we only got a few more minutes before we want to kind of move into questions. But when we talk about that, and I'm hearing what's being said, and we talk about these traumas that affect them, are the tools that we have out there the for identifying anxiety, depression, caged, identifying substance abuse issues, are those good for migrant and immigrant communities as well when we start seeing these problems and we want to identify the symptoms that are coming out of them?
In my opinion, I think we have a long way to go in terms of either creating instruments that can accurately screen for and assess for psychiatric disorders for refugee populations, obviously, based on, again, cultural context and their background, so that it's, culturally responsive. Also, I think that, there have been several instruments that, at least for, and again, this is for each migrant population, it's going to be different. But I know that one of the instruments that has quite a bit of adaptability to different refugee populations, for example, the Harvard Trauma Questionnaire, the Hopkins Symptom Checklist, obviously the Refugee Health Screener. So those are kind of like the three that I looked at. I also had to look up. I had a school psychologist reach out to me asking for appropriate instruments to be used with Afghan refugee children. And that was even more difficult. So I had to go through the research and comb through it to see what instruments have been adapted for Afghan refugee youth. And then also, sometimes I had to go a little bit outside of just Afghans and look at, similar, like Pakistani or Iranian, or, to see if there's some similarity, because there just unfortunately isn't as much research as the need is on the ground here in the US.
I guess on the question of the assessment, again, I would agree and reinforce what Dr. Rogers has indicated, that it's okay to use the available standard techniques, but being mindful of the cultural variance that these techniques have, number one. Number two is using daily life, street life language and terminology to explain what is happening to people. For example, the issue of sleep hygiene. Literally, my mainstream US-born clientele that we serve, I find that out of 10 patients, 7 are experiencing some form of sleep disruption. This is the mainstream US-born client. My numbers go up to about 8.5 out of those 10 for the US-born client at any one time living with daily stresses of life. When you're dealing with the immigrant populations, those that are recently arrived or previously are arrived and resettled, supposedly resettled now and mainstreamed, their sleep hygiene, that number for me goes to 9 out of 10. And so that sleep hygiene is a very easy, known, self-rating health issue that can be reported by the individual, by their loved ones, by people that are co-workers with whom they go to work and work with, or classmates, and if it is for students. So I'm referencing that those day-to-day life experiences can help us understand the symptoms in a very good way that can reinforce clinicians in assessment and then aiding in prevention.
Yeah. So what I heard and what I heard from you all is that the tools can be fair partners, but we still need to be culturally competent to the populations we're serving. We have to remember that they come from different cultures, and since culture is the sum total of all of our life experience, coming from different cultures and having to deal with this culture can actually be an increase in some of those signs and symptoms we see, including sleep issues. I know I've seen it. I developed a program in Chicago for Venezuelans, and I saw some of those sleep issues. Well, especially those living in cars, unfortunately. But yeah, I saw some of those sleep issues. It's about 2:48. Let's try to move into our questions. So if people have questions for our panelists, and I'll probably be asking a few too.
Dr. T, there was a follow-up for the panelists about the higher vibrational work. Any initiatives that the panelists have implemented to bring some of that higher vibrational energy into the workplace, or any suggestions for that?
Yeah, unfortunately, I don't have anything for you. If it was directed towards clients, I could say yes. We definitely had initiatives that were kind of higher energy with clients, with Afghan women specifically at the bases where we would have, tea and talking, and then we put some music on, and then everyone, it was just kind of became a dance party. And that was extremely, extremely satisfying, not just for, I think, the clients, obviously, but also for the professionals that were there to help them. So, but in terms of in an employment situation, I have not experienced anything like that, unfortunately.
When we talk about attempting to bring forward those higher vibrations, I worked at a place called Habilitative Systems. And one of the things that they would do, because they understood how often we carried the weight of the populations we served, once a month or so, they'd have little events. And I remember I ended up on the side of a billboard in a cowboy hat because they had a little event where we all wore Western gear and gave food. Once a month, they would do a healthy food event where everybody would contribute, and they would bring in like baked chicken and sauteed vegetables and things like that. But the real point was these were higher vibration events because it gave people the opportunity to kind of get a break from the day to day. Working with the populations we work with, migrant populations, we run into situations. Just working with the socioeconomically deprived in general, we run into situations where we're dealing with issues of homelessness, and we're carrying those weights, and we're trying to figure out how to come down. And sometimes just doing those types of things together gives them an opportunity to know that they're supported. I just thought I'd add that little tidbit.
I actually do want to add something. Right now, where a lot of our staff is remote, but when we were in person, I noticed that in my organization, we had a lot of birthday celebrations. And that kind of just gave you some time to be like, oh, okay, you cut cake, there's decoration. And then that was just something that was nice and appreciative.
Awesome. Just Dr. Rosalind, like, when you described your experience, did you see how like you lit up? You lit up when you were describing your experience, and that's one of the reasons why. And I think right now, like especially in this current environment, to be purposeful around this, to offset the wave that's coming at your community, is really so important. But it's a different way of approaching it. It's being purposeful. Like, how do we add? I mean, I've been doing it for 35 years around the Southwest, working with multiple, tribal communities and from prisons to name it. I'm known as the celebration ambassador, the CEO of Human Impact Productions. But my biggest thing is really going into organizations like your all's and asking, like, number one, where is it in your business plan to add that? And two, where is it in your budget to add that? And one of the challenges is that a lot of the foundations and people that pay money and support you guys, they don't see that as part of the work you do, the birthday parties and things like that. So it is a challenge because sometimes it doesn't match up with your funding. But it's just being on purpose with it. But I believe right now it's so important for us to collectively figure that out and add that. If they furlough 10 people, we need to show up with 100 people and music and food at the nearest park, So that's my little chime. But I'm 100% on board. So reach out to anyone, and I will volunteer to advise this group and share the multiple ways that you guys can do this.
Yeah, I love all the feedback that you gave, and I love that you are the celebration guru. But I provided a training on secondary trauma, burnout, vicarious traumatization, and in terms of recommendations, one of the things, and I know I have a family member who works for a company that has this, and I've heard of it before, but like even having a space, a physical space that has games or activities or things that you can just let loose and be silly and be playful and get out of that work mode, I think is extremely important in mitigating stress and burnout, professionally. So I love that you brought up the question. Thank you.
Yeah, that was definitely an excellent question. So we're going to begin to kind of summarize things. Dr. Mishra did say that we could, look at that as necessary for morale and retention, and that language is important when we start talking about those things we do, and when we talk about those celebrations. Um, so basically, what we've in summation, of what we have here, we've had an opportunity in this learning community to take a closer look at some of those issues that we see on a day-to-day basis, and we've had an opportunity to get a better understanding of some of the connections that we need as organizations and the importance of maintaining our mission in order to provide the best service to the population, of migrants and refugees. Yeah. We'd like to take this time, of course, to definitely thank our subject matter experts, Dr. Rosalind Rogers, Dr. Gaurav Mishra, and Dr. Sebastian Simpija.
Excellent.
Did I get it, Dr. Sebastian?
Yes, you did.
I was working on it. So we'd like to really thank you all for coming and providing for us, and we look forward to having you in the future. You all have done an excellent job. As you know, kind of done the summary, but I want to make sure you know that we here at RMTAC are completely prepared to assist you as you are making changes and doing things. One of the things you can do is you can put a CTA request in. We can actually give you some consultation. CTA request is very simple to put in. If you look right here, it shows you how to submit it, how to go to RMTAC, how to click on that request, and how to type in the information needed. A lot of times when we're out here working, we've also put the link right there in the chat. We'd also, it's very important that you guys complete the survey at the end. You're going to see both I can't always remember what those little square things are called. I'm terrible. And a link in the chat, a UR code, that's it. And a link in the chat. Also, we definitely want to see you next week, April 9th, at our crisis and de-escalation for pathways to recovery that we'll be doing. That's the second part of this, and that's going to give you a lot more information. And invite any other organizations that you feel would be great to be involved. Next week, we actually have our expert panelists of Amy Dominguez. Of course, Dr. Mishra will be with us again, and Alinga Alokola will be with us as well. We'd like to thank you all. We'd like you to stay around. Please click on that QR code or hit that link in the chat and do that survey. It takes just a few minutes. It'll also help you when you submit for CEUs. If you're one of those, so like I'm a certified addictions counselor, and I know with like LCPCs, there's this little form you can fill out and pay $10, and they'll give you a CEU when you've done workshops, but they need to know that was there an evaluation and all that kind of good stuff. And this is your opportunity to do that. We really like to thank you all for coming. You all have been great. We look forward to seeing everyone next time. We're definitely thanking our panelists, our subject matter experts. They knew a lot, and we probably could have done 3 hours. We may not have gotten to everyone's question during this, but please submit those questions. And what we'll do is we'll handle them in one of our CTA requests. You can submit them through the CTA request as well.